about what's going on in device therapy for heart failure. These are my conflicts of interest, which are a little bit blurred, but I think you can see it's almost impossible to do research in the modern world without having conflicts, but they're all there. So first of all, why are we even discussing ICDs, right? We've got tablets that reduce mortality in patients with heart failure. Well, first of all, bear in mind that sudden cardiac death is still incredibly common, both in the general public, but also in heart failure. And we have this graph, don't we, from 10 years ago now almost, saying that sudden cardiac death is going away and we don't need the hammer of ICDs. But of course, if you look at it in more detail, and I urge you to look at the bottom left of the picture where you see the treatment arm of CBIS-2, which many of you will remember is the beta blocker, the bisoprolol study, and then next to that is SCUD-HEFT, the placebo and the treatment arm, and the two are lined up. And then on the right of the picture, you see the treatment arm of PARADIGM, which is sacubitril valsartan on the background of a beta blocker and an MRA, and you can see that the treatment arm of PARADIGM has the same rate of sudden cardiac death as SCUD-HEFT did. So do not be fooled by people that tell you that sudden cardiac death is going away. More importantly, remember, the better you treat your heart failure patients with heart failure therapies, the longer they live, and the more they accumulate the risk of sudden death. So the longer they have to be exposed to sudden cardiac death. So ICDs are not going away. And ICDs are the only way of treating a terminal arrhythmia. I'm going to leave that there. There is no other way to prevent your patient at home dying of sudden cardiac death than an implantable cardioverter defibrillator. And here is the Kaplan-Meier curve from PARADIGM. You can see they still die, these patients. So risk is still there, even when using the doyen of heart failure, sacubitril valsartan, which is a fantastic treatment for heart failure, given all of the little labels on the chairs here, but nevertheless doesn't stop people dying of sudden cardiac death. If anything, increases the proportion of death due to sudden cardiac death, and you'll see this graph describes that here. And we've got more than 20 years of information on ICDs. They work across the board. There's almost no heterogeneity. And look, in SCUD-HEFT and in MADE-IT, the use of beta blockers was actually quite high. Don't tell me that in day-to-day practice we get much higher than this. Yes, in trials it's always 95%, but in real world, even Gianluigi sitting over there will tell you that in the real world, beta blocker usage is not much higher than it was in SCUD-HEFT. On top of that, there's good data that even patients who are remodeled still suffer cardiac death, sudden cardiac death, and benefit from an ICD. Here's some data from SCUD-HEFT, and we also know from observational data that if you add optimal therapy to a device therapy program, you will gain additional benefits. So don't put ICDs to one side. Here, finally, are the data from PARADIGM showing you that in countries with a relatively high ICD usage, your rate of death is lower than in countries with a relatively lower rate of ICD usage. So ICDs are not going anywhere, even in the CRT population. Here again, hugely popular paper when it was published. And yes, of course, if you've got a non-ischemic cardiomyopathy where left bundle branch block is the etiology of the left ventricular dysfunction, it's a great treatment in the absence of an ICD. But I put it to you that there is a subgroup of patients within here who benefit hugely from an ICD in addition to their CRT. And you'll see here it's particularly the younger, particularly those with scar, particularly those with an etiology that is not driven by left bundle branch block. And bear in mind here, this was a population of survivors. These guys had already survived for more than 12 months, and many of them already had a device in place. Moreover, Gianluigi has published this paper now 6 years ago, and I was lucky enough to examine the PhD of Benedict, who was one of the most fantastic PhD students I've ever had the pleasure to cross-examine, showing that in a population of patients in Sweden, where there is a socialized healthcare system, so they don't pay for drugs, they don't pay for treatments, even there, the rate of ICD usage is too low, but those people that get an ICD still benefit. And without heterogeneity, and you can absolutely include in that population those patients who get CRT, benefit from having a defibrillator mated to it with a reduction in total mortality. And the reason we use an ICD, of course, is that we are not very good at identifying when and where things are going to happen. The challenge with ICDs is that we have the competing risk issue. If we think the patient is going to die of something else, then an ICD can be a hindrance, can be an inconvenience to that patient. And certainly, as they come to their end of life, it is useful to consider turning the ICD off, leaving the CRT, if that's there, leaving the background pacing for an ICD, but turning off the shock therapies. So what else is being discussed in the modern world? So having said that ICDs aren't going anywhere, what is happening? Well, we have transvenous ICDs, we have subcutaneous ICDs, hugely popular. I'm not entirely sure why, but they are hugely popular. And of course, we now have the new Medtronic extravascular ICD, which does provide an option that I think will grow over the course of time. So the question is not if my patient should get an ICD, but perhaps which ICD should they get. And there are disadvantages to transvenous ICDs, I agree. Pneumothorax and lead displacement, but they're really only in the first few days. And if you have a decent volume, these happen almost never. At least they should happen almost never. If you're only putting in 5 a year, you should probably stop doing it and let somebody put them in that's doing 100 a year. In the long term, of course, inappropriate shocks, infection, and lead failure occur in transvenous ICDs, but actually relatively uncommonly. And you can see here that actually an infection with a transvenous ICD is very low, mainly at the time of box change. And if you program your ICD properly, you don't need a box change for 15 years. For a subcutaneous ICD, the rate of infection is a little bit higher. Bear in mind where it's going under the left axilla usually, which is a challenge both in terms of hygiene, but also in terms of interference with arm movement. So there isn't a huge difference, no matter what anybody tells you, in terms of infection rate. Lead failure rate is another thing. Lead failure rate for a transvenous ICD is incredibly low with modern leads. With a subcutaneous ICD, the rate is also not particularly high, again, dependent upon implant technique. Tricuspid regurgitation, of course, is something that we discuss, and we'll discuss about it a little bit more when we talk about CRT in a moment. Tricuspid regurgitation doesn't occur with a subcutaneous ICD. But I'm going to ask you guys, when was the last time you saw a patient with heart failure and reduced ejection fraction get worse because of tricuspid regurgitation? This is a non-problem. I've never seen it. My patients have HFrEF. They're on 4 tablets. They've all got an ICD. A lot of them have got CRTD. Where are all these people with severe tricuspid regurgitation due to device therapy? I really don't think this is a big problem, but obviously other people feel that it is a problem, particularly if you're the manufacturer of an extravascular ICD. The big problem for extravascular ICDs is, of course, inappropriate shocks. With a transvenous device, inappropriate shocks should be almost zero if you're programming them appropriately. This is not the case for subcutaneous non-vascular ICDs. Here is the Praetorian study published a couple of years ago now, a head-to-head randomized comparison of transvenous versus subcutaneous ICDs. The 30-day complication rate, very similar, give you that. High volume, experienced centers implanting this. Inappropriate shocks were a problem, and this is something that needs to be dealt with. These are all of the studies showing inappropriate shock rates in this procedure, in this device approach. You can see they're all well over 5% per annum. So even if you are very, very careful, your patient, your usually young patient who still wants to exercise, who has an indication for an ICD, if they receive a subcutaneous ICD, there is a good chance, 1 in 20, that they will have an inappropriate shock. No matter how hard you try, in the real world, this is still a problem. Now, there was a comparator study looking at 2 projects, the Praetorian study and the Atlas study, both published relatively recently, putting these 2 together in a meta-analysis, still confirming that there is a problem with first inappropriate shock due to oversensing and electromagnetic interference. Now, I know that EMI is something that perhaps we haven't concerned ourselves with too much, but I know for a fact that India has gone from an electrification rate of maybe 30 to 40% to over 99% in the last few years, and EMI is a big issue that you guys are going to have to deal with over the course of the next few years. Now, you can train the subcutaneous ICD, and that can somewhat ameliorate your risk of false shocks. So something to think about. This is the new Medtronic device. This is the pivotal study published now 3 years ago, but keeps being presented. This is a young population of patients. This is not the average patient that I see in my clinic, but it's a very reliable device. Successful ATP can also be provided, and they can pace, and it's not so painful. Lead dislodgement, relatively uncommon, so this is something that we can think about going forward. But this is not suitable for people who've ever had a thoracotomy. It's not suitable for people who've ever had some sort of upper abdominal surgery. So it is something to think about, but it's not going to be suitable for all. There are other things coming along with ICDs. For example, what happens in the post-infarct period to these patients? Are we going to take people with a dilated cardiomyopathy, a non-ischemic cardiomyopathy, and not give them an ICD? Can we use SCAR on an MRI to help determine who needs an ICD or not? These are some of the things that you should keep an eye out. I think for a non-ischemic cardiomyopathy, or let's say a dilated non-ischemic cardiomyopathy, you're going to often do an MRI before you make a decision about implanting an ICD. I do not think this is ever going to be the case for patients with a clear ischemic etiology, because there are still no outcome studies for patients with a non-vascular ICD. I think we're going to be limited in our usage of these to special subgroups of patients. So what's new in CRT? CRT is my love. It's the thing that drew me to device therapy when I was a young doctor excited about beta blockers and ACE inhibitors in the early 2000s. I then realized that for patients with conduction tissue disease, there was this new fantastic therapy that seemed really hard when we all started doing it in 2020, 2021. Now, of course, things have changed dramatically. When I started doing this in 2004, it was a challenging procedure. Biventricular pacing using a lead in the coronary sinus and a lead in the right ventricle is now a routine procedure that can be done in under an hour. And it has a Class 1A indication. Why? Because it works. It is a fantastic treatment for people with conduction tissue disease. Don't let anybody ever tell you difference. This whole concept of, I can't tell if my patient's going to respond or not, is a misnomer and something that is entirely pointless for us to consider. We do not discuss whether or not the patient should get a beta blocker or an ACE inhibitor or an MRA or sacubitril valsartan because they might not respond. That's complete rubbish, okay? We don't stop the beta blocker if the patient comes back to us 3 months later saying they don't feel any better. We certainly don't reduce the dose of sacubitril valsartan if we don't see an improvement in their NYHA class. Why would we do this with any other treatment for heart failure? And so we must not try and predefine our patients based on some internal belief that they are or are not going to respond to this. This is a treatment that improves prognosis in a wide population of patients. And it works. Okay, we must not do this. That's why it has Class 1A indication, and that's why we should consider it early in the treatment paradigm for people with HFrEF. If we delay, there is a risk that our patients won't come back, not because they've responded to sacubitril valsartan in the presence of left bundle branch block, but because they're dead. Okay? This is a huge problem. Under-treatment of left bundle branch block is the major challenge for device therapy, not the sexy new CSP, not the ICD yes or no, that we should put extravascular yes or no. The challenge for device therapy in the modern era, even now, is under-treatment of left bundle branch block. Because the longer we wait, the more they suffer. And they never catch up. You'll see here the red line is people that have been treated late for their left bundle branch block. They do not catch up. And this has been proven now in many different studies. The first study was our study, which is, of course, by far the best. But there are also other studies here. There's a population study from the UK, but also Professor Zavarese, I realize, is also publishing on this. Interestingly, as usual, the Vita group published first and everybody else comes later. Isn't that right, Gianluigi? Are drugs more important than devices? Well, no. But you should use the device and its benefits to optimize the medical therapy. Here is something absolutely published by the Zavarese group showing that you can up-titrate the drugs and you benefit from that. Clearly, you've got a device in place. You should now bang up the bisoprolol to 10 milligrams. No question. Doesn't drop the blood pressure particularly. The only disadvantage with a beta blocker is the lowering of the heart rate. You've got a device in, the heart rate can't go low, 10 milligrams of bisoprolol. Yeah? Am I running out of time? No. Okay, good. I've got a bit more time. So the additive effects are absolutely there. Don't refuse the patient optimal medical therapy. And if they get a benefit from their CRT, don't take away the drugs. I'm going to run over a few minutes because I do want to focus a little bit on this. I hope you'll give me a little bit of extra time. What about CSP, conduction system pacing, as a method for CRT? Hugely popular, lots of enthusiasts. There's enthusiasts in Central Europe, in Zurich, who are popping in CSP for everybody who's got left bundle branch block. There is no indication for doing this yet. So if you see a patient with left bundle branch block, CRT with 2 leads is your way to go. And if you can't do it, phone a friend. Don't give them an unproven therapy yet. CSP is, however, a reasonable option for people who need a pacemaker, for people who've got mild LV systolic dysfunction, if you can do it. The challenge is, can you do it? Can you do it better than you can CRT? And often, the case is no. Often, people are putting the leads in the wrong place. Often, the leads are causing, because of the position, more tricuspid regurgitation than you would if you had a right ventricular apical lead. And the success of implantation, proper implantation, even here in these centers involved in this prospective study, is lower than I would expect for a CRT using a CS lead. If your implant rate for an LV lead in the coronary sinus is under 95%, you should either do more or you should stop. And I'm being serious here because this is a serious issue. If we're undertreating our patients due to our own inability to accept that we can't do it yet, then we need to get better at what we're doing. In the same way as if I have a nurse who's tentative about up-titrating the medical therapy, I will give that person support so that she or he can optimize the medical therapy confidently. And the same thing is true for device therapy. So the learning curve for CSP is 100 cases. So unless you think you're going to be able to do 100 cases in the next couple of years, don't even start. Right. There are higher rates of tricuspid regurgitation. There are lots of comparator studies out there, CSP versus CRT, showing CSP is better. Be very, very cautious. 40 patients, that isn't enough to convince me that this is equivalent, and this is unselected pieces of work. There are some larger studies out there. Again, here, a systematic review and a meta-analysis is not the way to create a class 1 indication. I know I'm right with you. Is it an alternative to CRT? Here is a big study that shows us perhaps we need to be a little bit careful. This was a study with where patients were randomized with a plan to show it's not inferior. So this isn't even a superiority study. The threshold for achieving non-inferiority is relatively easy. And so they did this study in Brazil, relatively experienced centers. You can see here, class 1 indication, patients with broad QRS, left bundle branch block, LV ejection fraction under 30%, proper randomization with good outcome data. These were relatively young patients for my population, perhaps less so for your population. 50% of them were women. They had important heart failure. You can see that they had important left ventricular dysfunction. They were on good medical therapy. So this is not a low-quality study. And you can see that the CSP location was reasonable. Reasonable. Not great, but reasonable. But they had a 91% position rate for the CRT, so they also weren't achieving my 95% threshold. Primary outcomes were important: death, heart failure hospitalization, urgent heart failure visits. Here you'll see a nice pictorial example of the fact that CSP is not as good as biventricular pacing. In fact, it's also not as good in terms of LV remodeling. But we won't even go there because we care about patients, not how their heart looks. But nevertheless, LVEF wasn't improved as much. It is a reasonably safe procedure to do if you can do it. Of course it is. Any pacing procedure, if you're capable of getting into the subclavian vein, is a reasonably safe procedure. But nevertheless, this was not as efficacious. Therefore, this was published by my group, Professor Sevaresi, I'm proud to say. We are not convinced that left bundle area pacing is as yet an alternative to biventricular CRT done well. We have lots of evidence that still needs to be collected. The durability of the leads is also a problem. Think about this. We're already considering that the septum has some really complex internal movements, and we're putting a lead through that. Are we not interfering with the complex endocardial and extra movement of the septum? I've lost my button now here. Where's my button gone here? No, hang on, I've turned myself off. How do I do this? There, right. And so if you are thinking about conventional CRT, you should do conventional CRT. If you can't get the lead in first time, consider phoning a friend. And if that friend can't do it, then consider putting an LV lead into, or a lead into the septum. But only then. And that's why the European guidelines have come out saying biventricular CRT is the way to go. Very strong 1A indication. If you're doing CSP, first line, you are not following the guidelines or the evidence. Finally, what about HFpEF? Heart rate is increasingly recognized to be important in HFrEF. It does seem that if you optimize the heart rate, you can improve some patients with HFpEF, with stiffness, with poor filling, perhaps elevating the heart rate from 60, where we've always traditionally had it, to 70 or 75 might be of benefit. This is a heart rate algorithm based on height. Gianluigi, your heart rate programming would be very challenging in this situation, but for me, I would have a heart rate of about 60. Maybe Gianluigi would have a heart rate of about 120. That is the paradox here. I don't understand this. Bigger study needs to be done because it is, quite frankly, a very challenging concept. On the other hand, simply treating the chronotropic incompetence does not work. We all know this. Chronotropic incompetence is as frequently due to lack of action, lack of exercise, lack of training, lots of other problems, as it is due to an intrinsic cardiac problem. And so, at the moment, simply chronotropic incompetence is not a target in HFpEF because overall there's no benefit. So, ladies and gentlemen, to summarize, ICDs are still in. Transvascular ICDs are probably your first line. A single-chamber transvascular ICD is a fantastic treatment, and the batteries last a really, really long time if you program them carefully. Non-intravascular ICDs have complications all of their own, and we're still learning about them. And one head-to-head study probably shows a parity of risks, but in very selected population of patients. And despite more than 10 years of marketing, subcutaneous ICDs still come with no outcomes data in the population of patients that they're treating. Whereas a transvascular ICD gives you pacing ATP and the upgrade potential, which you don't have with a non-vascular option. Finally, CRT is still a big deal. It should be a biventricular approach first and foremost. It is absolutely not worse than CSP, and probably at the moment the evidence based on the guidelines suggests that should be your first port of call. And heart rate might be important in HFpEF, but you need to avoid RV apical pacing and participate in a study rather than just doing treatment for chronotropic incompetence blindly. Thank you ever so much. I'm sorry I overran, but I hope it's been fun.